Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined from the faraway Dr. Lisa Pabst in Utah. Thank you so much for joining me today.
Thanks for having me. It's really an honor and a privilege. This is my first podcast, so really excited to be here.
Well, if you don't want to be on another podcast, I'm sorry, probably you're going to get discovered or something. They'll be like,
This is my big
oh,
break.
I guess, I don't know. It's funny how that works as podcast, that it's like this snowball effect thing. Um, but Dr. Lisa Pabst is a pediatric stroke neurologist, and she works for the University of Utah and also at Primary Children's Hospital because she can't limit herself to only working in one place. But and then, are you from Utah originally?
I am not. I'm actually from a small town in Texas.
Okay, awesome. And you went to med school in Texas, right? In Houston?
I I did, yeah. I went to college and med school in Houston, and then I went and did all my training in Columbus, Ohio, and then I lived out here in Salt Lake City for about 3 years now.
Fantastic. So, I'd love to learn some more about your background. We were introduced by a mutual friend that you went to school with, and I met in an elevator at the stroke conference. um, because we've been learning about how to ramp up a pediatric stroke program here in Kentucky. And so I
Mhm.
had my eyes open for pediatric stroke neurologists, which are not as numerous at big stroke conferences. But I'm
Yeah, no, it's a small field for sure. I think as a
Mhm.
little background, so going back to Texas, I grew up in a really small town that's in fact not a town, it's an unincorporated area of a county. But it's not far from Houston, so like less than an hour away from Houston. And I decided, probably around high school that I wanted to go into medicine, and I was interested in neurology from the beginning. I was really intrigued by the concept of localizing the lesion so that if you understood what a dermatome was, for example, that you could say, oh, this pattern of numbness means you have a problem in this level of the spine. And that really drew me in. And so then I went to college and went to med school as planned. And the very first year of med school, we started learning about basic diseases, including things of like genetic diseases and stuff like that. And it became really clear to me that I really loved, like the pathology in kids, if you will. I was much more interested in any sort of problem that affected a child, and so I further honed in really early on pediatric neurology. And then I got to go to a conference, the Child Neurology Society meeting, which is like
Mhm.
the biggest kind of pediatric neurology dedicated conference in North America every fall. And I went there in my third year of med school. And that year they happened to have this big symposium on pediatric stroke. And I had learned a lot about stroke in med school, but in adults, like we never talked about it in kids. And so I was almost like surprised to hear that kids had strokes at that point. But
Mhm.
was even more surprised to hear how different it was than in adults. So like you have the same disease, which is, something terrible happens in a moment, brain cells die, and yet kids do really differently. I remember learning about a teenager with locked in syndrome, where normally like an adult wouldn't be able to move their body, they would only be able to move their eyes, but like this teenager actually recovered quite a bit. And so I like became really interested in that, and went on to do like a project the next summer. I went to another institution to work with a pediatric stroke neurologist who's continued to be a great mentor actually now for many years. And From there, it's like always been, I've always wanted to do pediatric stroke. And so, as I got into my pediatrics training, my neurology training, I realized how much I really loved kind of the acute care, the like really high stakes, like high pressure environment. That's like really where I thrived, and where I like love to be on a daily basis. It's really like such an honor and a privilege, I think, to take care of kids at those most critical moments in their lives and to be there with their families and like what is some of the scariest moments, and then to continue taking care of them afterwards. And so it really just like continued to kind of hone in on that. I think the other thing in my background that's worth mentioning is, I come from this like small, not real town in Texas. And it was really eye opening to me to then go to medical school in Houston, where there's the world renowned Texas Medical Center with these like top tier, hospitals like MD Anderson, where people come from around the world to go get like cancer treatment, for example. And to kind of look back and see like the medical care that people in my family or acquaintances had gotten living less than an hour away versus like the care that I saw was possible in in the Texas Medical Center. I felt like, wow, like why is there such a big discrepancy? What are the barriers to people getting like the best care? And so I on the one hand I chose this field that's like a pretty rare disease. It's very limited to care in a tertiary children's hospital, right? Because that's where like kids with strokes go. But I also continued to have this love and this passion to like, but what about everybody who doesn't live in the in the city with like a tertiary children's hospital, and how can I like work on both of these things? And so I was really interested in figuring out how to merge those two interests, and that's what led me to Utah, where I fortunately work in a great academic institution at a children's hospital that covers a huge portion of the United States. So this is considered the Intermountain West, and there's like a population of what, about probably 30 million people, I think the last time I checked, in this region, which is only 10% of the US population, but geographically, this makes up like a quarter of the country. And so it's an interesting challenge to figure out how do you take care of kids across this huge area, and how can I do it just as effectively for a child who lives 10 hours away in Montana as I can for a kid who lives in Salt Lake City. And so that's kind of where how I landed here.
Yeah. And, on this podcast, I interview a lot of innovators and even inventors, and definitely people who are using their experience in healthcare to make things better. And so when I heard about your work to create a pediatric telestroke program, I had to meet you. It only took from February to September for us to both have our schedules align. But so when you came to Utah, was it
Mhm.
your plan at that point, or was it their plan to have you start a telestroke program, or is that something that you really had to push and fight for there?
Yeah, so it's actually it was an interest before I came here. So when I was in my fellowship, part of my stroke fellowship was taking care of adult patients with strokes. I won't tell you how that felt to me, but as a pediatric neurologist, but it was really important learning.
Mhm.
But I got to participate in telestroke, where we would, evaluate an adult stroke patient remotely from 2-3 hours away, and like help make that decision of what to do with that patient in the moment. Are they having a stroke, are they not, should they get clot busting medication, should they be transferred for thrombectomy to remove a clot? And I thought like, wow, that's like that's so cool. Why don't we do that in kids? And there's a lot of barriers to even setting that up. It's taken, I think, like the first like report of doing telestroke in adults happened back in probably like 1999, where they described like that you could examine an adult over camera essentially, and then like telestroke has grown significantly since that time, but it's been many years in the making. And so when I was a fellow, I first wanted to say like, well, can you even examine a kid over camera? Because one of the first struggles that we have is, a lot of kids present to other hospitals, right? Because again, most kids are not, or many kids do not present first to a children's hospital that's like ready with a pediatric stroke code.
Mm.
And one of the struggles that we often hear is like, well, I don't know what their exam shows there too. And if somebody is not used to very regularly doing a neurologic exam on a
Yeah.
2-year-old, I can understand the challenges. And so as a fellow, I was like, well, why don't I just start by seeing like, can I do an exam over camera for the pediatric NIH stroke scale, which is very similar to the adult stroke scale, like a numerical scale where you kind of do a series of things like holding your arms up, smile,
Mhm.
talking, things like that, and you assign a number, and the worse the number, the more severe the deficit or the stroke might be. And it's an
Mhm.
important part of making decisions. And so I did this very small pilot project just showing like we can examine kids over camera and assign that number with good accuracy compared to somebody doing it like in the room with them. And so it was already on my mind. And as I started looking at jobs, I talked a lot about that, and I talked a lot about, my interest in like why not do this for kids? It's made a huge difference in adult care. like with adult telestroke, they've improved the access for adults receiving thrombolytic or clot busting medications. So like, why not do this for kids? And some places were really interested in this idea, but some places were also like, no way, like there's too many barriers. You have to get licensed at all these places. It's too rare. It's not worth the time. But when I interviewed out here in Utah, they were like, yeah, we need that. And
Yeah.
they were already, innovators. And I should say, like, I don't speak on behalf of Intermountain Health or the University of Utah. Everything is my own, experience and opinion. But I was really struck by how Intermountain Health here was already being really innovative with pediatric telehealth. They were already doing things like remote resuscitation where like a NICU doctor or an ED doc is like helping some hospital many hours away getting on camera to help with a pediatric trauma or a kid who comes in, in arrest. And so they were already doing things that most other hospitals weren't doing. And so A, the infrastructure was here to some extent, but B, they were interested because Intermountain is very much about taking the best care of the child as close to home as possible. And so it was a natural, good fit. And so really from even before I got here, it was something that I wanted to do that, the hospital I was at was interested in developing. Um,
And
so
what
it,
year was
yeah.
that? What year did you come to
So I
Utah?
came here in 2022. It took a couple of years to actually get going. Yeah. So
And
we rolled out
also,
in 2024 with our
yeah.
pediatric telestroke service. Yeah.
Well, I think, with the pandemic, it made telestroke in general and telemedicine all over a much more like it reduced a lot of barriers because everybody had to
Yeah.
do things by telemedicine. And so that was really helpful because I know beforehand, I know when I first came into this role, we were trying to. So for the last 5 years, I've been calling stroke patients after they get out of the hospital. And before that, I
Yeah.
did 8 years in the stroke ICU. And there was talk the whole time about telestroke from as far back as I can remember. And there was
Hmm.
always pushback until the pandemic. And then we had the equipment and nobody wanted to use it. And then all of a sudden there was the pandemic and everybody was using it. So I was kind of surprised that you didn't have it up and running before 2024. So is that just
Hmm.
because of the licensing and stuff you were talking about?
It takes, yeah, I think there's a variety of things. First, when I came here, there was just a general like building of a program that needed to happen. There were a lot of
Mm,
pathways that weren't in place quite yet in terms of things like what children should we give IV thrombolysis to, or like how can we really optimize the kids that we're taking for thrombectomy to remove an occlusion. And so there was a little bit of just like stroke care groundwork that was
gotcha.
happening. But it was also, I think there are real challenges to staffing pediatric telestroke. So adult stroke, there are many, many adult stroke neurologists. There are many systems of care that different hospitals use for adult telestroke. We're in an area where, I think right now the group that I'm in at like the university is we're like the only group of pediatric neurologists in the state. There's not other people that are currently practicing to my knowledge. And I have one partner who has a lot of experience and interest in stroke, but there's nobody else who's like a stroke trained neurologist. And believe it or not, because pediatric stroke is not a super common diagnosis that people have to make decisions on a regular basis. Many, I would say most pediatric neurologists are not that comfortable with the like acute care management. And so one of the first really big barriers we had is just like we roll out this telestroke network, but like who's going to staff it? Right? One or two people can't be on the hook all the time. That's not feasible because A, we have other important jobs that we do here as pediatric neurologists. And that's just like you need a group of people to do it. And so that was, one of the barriers was just like the manpower. Second
Mhm.
is, to like put the effort into licensing and credentialing. So we needed to be credentialed at every hospital where we were going to provide this service. And that is resource intensive on behalf of those hospitals, on behalf of the people who, on our end, help with
Mhm.
credentialing and licensing. We needed licenses in other states if we were going to, practice in other states, things like that. And if we see a lot of pediatric stroke at our hospital, actually. I mean, we're like, it surprises me how much we see. Um, I don't know if it's the altitude or what. I'm still trying to figure this out, but we see
Right.
quite a few kids a year, but it's still not like the volume's still not that high, right? So like there we can certainly go a week without having a child come in with a new stroke. And so also, how do you justify, like, having one person who can do other things, right? I can go see consults in the hospital, I can see kids in clinic, but how do I keep myself that available in case a telestroke call comes? And so there's a little bit of like, how can we strategically keep somebody who's trained to do this available, but like
Mhm.
not use that resource appropriately. So building, we needed to build more than a group of one or two people. We needed to have a core group of neurologists who could do that. And so there is a lot of training that we had to develop um, to do that. And ultimately it also came back down to this time concept, because we take care of many kids as a relatively small group of neurologists here. And so we needed to make sure that like the service that we were offering was still in the best benefit to the overall region and wouldn't take away from other care we could provide. And so ultimately, what was really helpful is we paired this pediatric telestroke service with an acute care pediatric teleneurology service. So we have a person who's available to take a telestroke call, and they're really available to do that. They're available to like answer the phone within 5 minutes, get on camera in 15 minutes. But it's not a day wasted if that call doesn't come, because they're also available to do any other teleneurology call. So if a child presents to a hospital several hours away with status epilepticus, new onset seizures, altered mental status, whatever, they're able to do a consult for that. And so we're still able to like essentially make it worth the time, in terms of, still providing a good service to the kids in our region, regardless of what the neurologic problem is.
That is fantastic. And I think we really need to take a minute to talk about the need. Like you said,
Mhm.
there's more than even you expected as an expert in what to
Yeah.
expect, right? So, something Dr. Stuart Fraser said to me at the International Stroke Conference where we met was that stroke is in the top 10 killers of children, but
Yeah.
there are different causes of stroke in children, and I think, as you mentioned, they have different in their resiliency and the way that their neuroplasticity probably works differently than adults as well. But could you speak to some of the causes of stroke in children and how that's different from adults?
Yeah, definitely. I think, in pediatrics, there's this saying, right? Kids are not just little adults. And I think of all the fields, pediatric stroke probably highlights that,
Yeah.
because I think like the pathology is really different. So in a previously healthy child, so in a 7-year-old child who comes in with a new onset stroke, one of the most common causes is actually something called focal cerebral arteriopathy. It's a disease very, very rarely seen in adults, in fact, almost exclusively seen in kids. It often happens after your run-of-the-mill cold or some minor viral infection. And the thought is that, the immune system, instead of attacking like the virus or whatever set it off, starts attacking blood vessels, often in the front of the head, and will cause this like inflammation within the wall of the vessel and causes narrowing. And sometimes that causes some turbulent flow and you get a clot. And so it's a really important disease, actually, to highlight one of the differences in pediatric stroke, because it is inflammatory, it irritates the vessel wall, it can lead to a clot or it cannot lead to a clot. But the care of that disease is really different. In adult patients presenting with stroke, like two of the main therapies on the table at time zero are IV thrombolytic to bust a clot if there is one, or mechanical thrombectomy to take a catheter up into the head and try to remove a clot.
Mhm.
And in kids, if a kid presents with focal cerebral arteriopathy, those things may not be helpful.
Mhm.
Sometimes the most helpful thing in those cases is actually to put the child flat, because if they have a narrowed blood vessel, it's just hard for them to get blood flow to the brain. So putting them flat, giving them IV fluids, keeping their blood pressure up, that's actually one of the more important things up front.
Yeah.
Sometimes we will still use like that clot busting medication, especially if there's a clot. It still makes
Yeah.
sense to try. And I think the jury's out, honestly, on if we should try to do thrombectomy. These things are all off label in kids.
Yeah.
But like if you stick a catheter through an inflamed artery, are you potentially going to make things worse?
Yeah.
And so these are really extra tough decisions that we're making in the a rare cause of a rare disease. So that's something we see particularly common here. It's got an interesting geographic prevalence, like where we see more of that in the Southwest and the Western United States of that focal cerebral arteriopathy. They see it a
Yeah.
fair amount in Europe too.
Huh.
Beyond that, kids with congenital heart disease can certainly have strokes for various reasons related to abnormal heart anatomy and predisposing them to forming clots that can embolize to the brain. We see in general more kids with just frank vessel problems. So we see kids with moya disease,
Yeah.
which is often a genetic problem, but they get progressive narrowing and eventually like their arteries close off in their heads. And again, those are kids where like clot busting medications or trying to stent something open that is usually not the answer. And things like understanding that that's the disease to not actually do those things is really important. Because, we know like in the acute phase, again, putting them flat, usually giving them fluids, keeping their blood pressure up, those are really helpful interventions. Um, and then we have lots of kids where we think it's like the perfect storm of things. We have kids where we don't find the answer, but they were maybe a little sick and their immune systems overreacted and made them a little bit more prone to clots. They maybe have a PFO, which is really a common hole in the heart rate. 25% of the population will have it. But we do see it a little bit more in kids with strokes. So yeah, those are some of the ones that come to mind immediately, but I think are some of the really important ones that highlight why kids are not just little adults having strokes, and why their care is different. It's nuanced, and none of even those more common versions are still rare things that any one person is unlikely to see many times in their career unless it's the only thing they do.
Yeah, exactly. And I think earlier you were mentioning, I can't remember if we were recording it or not, but you were saying how sometimes you're not sure if the altitude contributes to the stroke risk. And
Yeah.
you're more likely to get dehydrated at a higher
Mhm.
altitude for sure, which can contribute to stroke risk. But then here in Kentucky, we say we have stroke weather sometimes because
Yeah.
we might go a week and have hardly any stroke patients as well. And then one weekend, we had 13 mechanical thrombectomies in 72 hours.
That's
So,
wild.
right. So, what can you comment on the concept of stroke weather?
I haven't, out here, I've not noticed it be a weather thing. The only time I ever care about the weather is when, I will say, with the exception of, I feel like children who are far enough that need to be transported by fixed wing jets
Mhm.
only happen when it is like a blizzard.
Mm,
Um, but that's probably just my own bias if that's when I pay attention where I'm like, we have to transport them by ground for 13 hours. Like what?
yeah.
No, I haven't actually noticed a huge change in the weather, but what we notice is that things come in threes. So like
Yeah.
we can go months without having to do a thrombectomy and then we will do three in a month or something like
Yeah.
that. The same thing goes with focal cerebral arteriopathy where they come in waves. And that one probably makes sense because I think that there are probably just certain viruses circulating that are
Exactly.
more likely to trigger FCA. And so we probably just see them at, particular time points and different infectious seasons of the year, right? And kids, we know there's this respiratory season, which is winter, when
Yeah.
RSV is really bad, the flu is really bad. So I think there are certain like viral seasons that are probably really important in terms of what we're seeing in kids with strokes.
Yeah. And that makes sense when it's an inflammatory process. Well, you and I were also talking, I know, before we started recording about how much sugar there is in Utah. Like in Kentucky, we have a lot of bourbon, which is a problem
Yeah.
for grown-ups. But in Utah, like I visited Salt Lake City and there's sugar
Yeah.
everywhere because they don't do as much alcohol and sugar's their thing. So,
Yeah.
and with grown-ups, when I'm educating them on preventing stroke, a lot of it comes down to like diabetes and blood sugar control. So, do you see a difference in like risk factors and how to prevent stroke for children? And does that contribute at all, or how's that work for you?
Yeah, that's a good question. I think, there's been a TV show that has made Utah's soda culture a little more infamous over the last year. A reality TV show I won't name, but it's
Why
highly
will you not
entertaining.
name it? Is it the
I don't know.
Real
Am I allowed
Housewives?
to?
I don't know.
No.
It's
Oh,
not the
maybe I
real
can name it.
hold on,
No,
is it the Real Housewives of Salt Lake City? Oh,
no, The Secret Lives of Mormon Wives. If you haven't watched, it is
no.
my greatest guilty pleasure.
Is it?
Um, it is top tier reality TV. But it is made so I think a lot of people have learned about the dirty soda culture because of this show, which is like, in other cities where you see a Starbucks on every corner, here you see a soda shop on every corner. Because a lot of people in Utah don't drink coffee and tea, but they drink
That's
soda
fun.
for
Yeah,
like
so it's
religious
not
reasons.
caffeine, not alcohol, but sugar, like,
Yeah,
what?
and so there's like there are all these drink chains. I mean, honestly, within a mile of my house, I could go to like five different options to get whatever dirty soda, and it's like wild the combinations. You can get like your Diet Coke with coconut cream and fresh lime and pineapple puree and like cinnamon on top. There's all these. It's like
And you mean
it's a
texture?
huge part of the culture here. Yeah, and it's a lot of sugar. But
So,
I digress.
when you say dirty, I think dirty martini, like there's olive juice in there or something. Does it
Yeah.
just mean they add in a lot of odd
It
things?
just means, yeah, exactly. It just means there's like weird toppings that you normally wouldn't necessarily put in soda, but it doesn't, yeah, no alcohol or anything like that. But it's
Also, there is a lovely speakeasy in Salt Lake City my friend introduced me to, just so
yeah,
everybody, but I
there
can't
are
remember.
there are good places to get adult beverages here, so I've heard. Um, yeah,
Like,
actually
I need
Oktoberfest is
sugar.
going on right now, but up at Snowbird, just up one of the canyons.
Right,
And there is beer to be had.
right.
But yeah, so anyway, I was totally struck by the amount of sugar that like the dirty sodas and then the cookies, right? So this is a home of crumble cookies, which I think has like
Oh,
infiltrated the
yeah.
country
Mhm.
at this
We
point that it started here. I think it started like in Provo, if I understand, which is just south of Salt Lake City, but like it started this craze of these giant elaborate cookies that probably have 1,000 calories in each one, and who knows how many grams of sugar, and it's a huge part of like you get your soda, you get your cookie. That's like what people do here. And so I have been surprised at how much sugar there is, but I'll be honest, I actually have not seen any sort of correlation in terms of like what that means for our pediatric population. And I think that I don't know. I don't take care of adults here, so I don't actually know if like diabetes is more prevalent. I do think people live a overall more active lifestyle here. Like I
Mhm.
live, I can be at four ski resorts in 25 minutes from my house and can go hiking year round. And like I think people are pretty active, and maybe that
Mhm.
offsets the sugar a little bit. But I
Okay.
actually have very rarely seen kids with strokes who also have diabetes. And if they do have diabetes, it's often type 1 diabetes and they're young and it had
Mhm.
nothing to do with their sugar intake.
Right.
That said, some of the diseases I take care of lead to long-term problems in kids' blood vessels that are not going to get better. And so I do a lot of talking about like, I'm going to really need you to have a healthy lifestyle as you get older. I'm going to need you to not, be that 25-year-old who has premature like cholesterol issues and diabetes and things like that, because one artery is already bad. We've really got to protect like the other ones. So we do a lot of talking about that. But yeah, I really haven't surprisingly seen a correlation too much to that part of our lifestyle.
Yeah. Well, that's really good to know. I mean, because that's just not a conversation I've been part of before. So thank you for that. This brings us to the big question that I ask every guest on the Nurse Rosa's Insights podcast, which is Dr. Lisa Pabst, if you were given a grant for $1 billion to meet the needs that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
That's a good question. And I answered this question months ago now, right? As you said, we've
Right.
been trying to set this up for the last 7 months. And I intentionally did not actually read my answer because I'm
Okay.
curious to see if it changed,
Okay.
if I'm any wiser or have any different opinions. But
Okay. Let's see.
I think obviously I have a specific interest in pediatric telestroke, and there are a couple of other countries that have used telestroke in pediatrics, but it's really not used elsewhere in the US. I think Kaiser in California like trialed kind of doing some pediatric telestroke. I'm not sure if they still do it, but it's really not a system that's used in the US despite a widespread acceptance of telemedicine and of these like or really elaborate adult stroke networks. And so that's I'll get to my point, I promise. But
Yeah.
um,
You have the floor, so you take your
okay, okay.
time. There is no rush.
Um, So I have, the point of that is like I am particularly interested in using telestroke in kids, and I think kids are worth so much more to me because when a 5-year-old child has a stroke, I hope that they have 75 more years of their life to live, right? And so I think like for any one child where we can make any difference in terms of how they recover from their stroke, I think it isn't just, worth it for the next few years or for things like that, right? This is a child who like their entire life trajectory, going to college, doing what they want to do as an adult, having a family, being independent, like all these things can change in the blink of an eye at such a young age. And so I feel really passionately about, acknowledging that kids have all these life years ahead of them. And so, to me, even though it's a rare disease, it affects maybe like if you're just looking at arterial ischemic stroke, depending on the population you're looking at, that's anywhere from like 2 to 10 per 100,000 kids per year in the United States. It's not common, but like those are kids who have many, many years ahead to live with that. And 70% of kids who have a stroke are going to live with a long-term problem afterwards. And and so that's part of where I get to the what do I think we can do with it and the why. The other
Yeah.
part of it is the pediatric stroke community is like the coolest community in my opinion. They are the most collaborative group of people because again, it's a rare disease. It's this like very close knit group of people that are pretty well connected actually across many countries and continents. And it, and I think that is such a unique resource. I think like some rare disease groups like you can get into this competitiveness, right? Because people want to be the ones to cure a disease, people want to be the ones
Uh,
that like have their legacy, and I totally get that. But I think like the pediatric stroke community is a pretty humble and collaborative collegial group of people who all feel very passionately about helping make a difference for the 70 years ahead that most of our kids have to live. And so I think it's such a unique group and such a to like leverage. And so what I would do if I just had like infinite resources is I would connect like this idea of using, networks that already exist, frankly. We don't even have to be that novel in many regards. Like all this, the adults did it for us in some,
right,
to some
exactly.
extent. They like
But
established this pediatric
yeah,
telestroke, but like connecting that resource with this incredible group of people who make up the pediatric stroke community to really like infiltrate the far reaches of the planet to reach more kids, to bring expert care to more kids, to make a bigger difference both like in that acute setting but also in the long-term care to help kids reach their best potential, to do our best to prevent them from having strokes whenever possible. Like think of like what a huge difference you could make if you could just connect the resources. And so I would leverage those two things. I would leverage this like the availability of telemedicine to this incredible community of people, to bring that expert care everywhere and put those systems in place everywhere. I think one of the not maybe unanticipated, but I've been surprised at how much of a benefit this has been in rolling out pediatric telestroke is just I think people are scared of it, and it makes sense to
yes,
me. Not everybody gets an adrenaline rush when they get a page that's like stroke code.
yeah,
Um, some people, when it's like stroke code 5-year-old, last known well 12 o'clock. I mean, I get it. That is palpitation inducing for some people. But I
mhm,
think people are afraid to ask the question, like, could this child be having a stroke? And I
yeah,
think that having systems in place that connect any place with a pediatric stroke expert, I think it empowers them to ask that question, first of all, of could this child be having a stroke? I think out of fear, people don't want to ask the question sometimes because they're like, well, what if the answer is yes? What am I going to do? Um,
exactly. And honestly, that part is the same for adults. Like, if you're
yeah,
not a stroke neurologist, stroke is scary. I mean, even
yeah,
for other neurologists, I dare say,
yep.
let alone these hospitals that don't have any neurologists at them, you know? So And then what you're talking about is even more niche as far as that expertise is a lot more rare. And therefore, there are even more people afraid of it because, like you said, they just don't know what the answer is if the question's answer is yes.
Yeah, and so I think, you know, connecting resources is ultimately like one of the great things that can be done to improve, the long-term outcomes of kids with strokes because we can identify them faster. We can make a difference sometimes with really simple measures like IV fluids. What do we do with the head of the bed? What do we want to do with their blood pressure? Like those things can make a big difference in terms of how big is that
Right.
stroke going to be or not be.
And that's
Um,
something that everybody can do. That's something nurses can do is
yeah,
part of that, And so I think letting people know and demystifying that that is usually the most helpful thing can,
yeah,
unless it's contraindicated by certain
of
other
course.
things. I'm sure you have to go through this whole
Yeah,
differential
there's
process.
always the nuances. Yeah,
Right,
yeah,
right. But
yeah,
having that in your arsenal of, okay, I don't have to decide between a clot busting medication and neurosurgery as the only things that we can do, it would
right.
be reassuring to a lot of people.
Yeah. And I think too, I part of implementing like a pediatric telestroke network is um I've had the opportunity to meet with lots of groups of people at these hospitals where we're offering this service. And in more meetings than one or two, I've had other physicians say, I didn't even know kids have strokes. And I don't blame them because there's a very good chance that you can go your career without seeing a child with a stroke, which is a good thing. Um, but even putting a system in place that
Mhm.
alone raises like the awareness of the
Yep.
disease, and it increases the chances of somebody even knowing about it, right? Like little kids presenting with stroke, especially babies, they don't look like an adult. They don't come in because they stopped walking, they stopped talking. They come
Yep.
in because they're like not feeding all of a sudden, they're drooling, they have a seizure. Like seizures are actually one of the most common presenting signs of strokes in especially small children. And seizures are common in general. But I think like these are the kids that we miss or we don't find in a timely fashion. There's, a statistic which I hope somebody other than me will come up, has the motivation to study this again. But I think it's about 10 years old now that two-thirds of kids with stroke present to a hospital within about 3 hours of symptom onset from stroke, but the time to diagnosis was about 24 hours. I mean, that's a
Oh,
huge delay. And time is brain.
no.
I think that's like an accurate, like time is
Oh,
brain. That is universal to babies, kids, adults.
yeah.
And I think that probably that number looks different because I think so much progress has been made in pediatric stroke. Like we have our first, or we have an active NIH StrokeNet funded trial on the care of kids with
Mhm.
focal cerebral arteriopathy. We've got many hospitals that have, good pediatric stroke protocols, like huge, huge milestones have been made in recent years. So I hope that number is different, but I don't know that it's that different.
Yeah.
And I think a lot of it is an awareness thing because kids
Mhm.
don't come in saying, I'm worried I had a stroke, right? Their parents are just like, something's wrong. And it can be really hard to identify. Sometimes parents even say, I'm worried my kid is having a stroke, and people still think it's probably not that because they're a child, even when parents have that concern. So,
Isn't that
um,
wild? Even though
yeah,
they at least are enough aware of what a stroke looks like to
right.
recognize their own child, and then the medical people don't think that that's a possibility. That's wild.
Yeah.
So, yeah,
I
you're
mean,
right, we need more
Uh, stroke
awareness.
mimics are more common in kids than actual strokes. And I think
Yeah.
that's a really important thing to acknowledge. And this is why this comes back to too, like, why is stroke care different? Why don't we just treat every kid as if they're having a stroke empirically? I mean, the good news is there's a bigger chance they're not actually having a stroke. And so some of those same therapies are actually not to their benefit and can be risky. Even, giving a child aspirin when in fact they're about to be diagnosed with a brain tumor and need surgery, right? That's not actually a totally benign intervention that we just did because we're like, well, better safe than sorry, just in case it's a stroke. Probably two-thirds of kids who are coming in with stroke symptoms are experiencing something else, though many of those things are real neurologic emergencies. And so I think like having these systems, having this
Mhm.
expertise available, regardless of where a child is, it makes a big difference, even for the ones who are not experiencing stroke.
Definitely. And, have you seen the kids book, Be Fast, Be a Superhero?
I have, yeah.
What, do you have it? Do you have a copy of it?
I don't actually have a copy,
We're gonna
no.
have to hook you up with a copy of that because, I know I definitely was using it on my kids and wanted to read it to my daughter's whole class at school because, like you said, if it's gonna happen in children, it's really important that they recognize it and realize it's possible. So, as we're educating adults, we also
Mhm.
have to continue to educate children, and they can recognize it in each other. So,
Yeah.
that's great. So, I think you can do it. Are you going to be presenting at like the World Stroke Congress in Barcelona or the International Stroke Conference in New Orleans in the coming year or anything?
I don't, not the World Stroke Conference. I think to be determined on a couple of other conferences next year. Our team is really eager, I think, to share our experiences and share the lessons we've learned. I think a lot of people in the field are like, wow, you guys are like, you're doing telestroke. How are you doing it? And it until you go through the process and understand just like the legwork it takes to get something up and running, I'm like, yeah, it's like I can see why it's a very daunting task to other people, but other people want to do it too. So
Mhm.
I hope that like we can partner with other people in other places because power in numbers. But I hope that we will be presenting at a couple different places next year on kind of the early lessons we've learned and and also like where we want to go because I think we've got a lot of work to do to really optimize what we're doing here and to better serve our region and to reach more kids. I think like we would like to expand what we're doing and always improve. And we just reached the critical 1 year mark where we're starting to look at kind of what has been our first year. What do we need to do better? So
Mhm.
I'm really excited to kind of get out there and share that experience and find people to collaborate with in particular so that we can kind of connect more kids in rural places to to the care that they need.
Well, your passion and your enthusiasm is infectious and palpable. So I know that the people who are like-minded are going to want to collaborate with you on that as well. And when your abstracts are accepted and you know where you're speaking, please let me know. I want to know. I want to hear from you if I'm there. Um, because I don't know which I'll be able to attend next year as well. But I really was disappointed to not get to go to Barcelona this year.
Oh,
But I went to World Stroke Congress in, Toronto a couple years
oh,
ago,
cool.
and,
Yeah,
it was amazing to see all these different people around the world who cared about the same thing,
yeah.
and, um, connecting with those people and staying in touch with them over the last couple years has been really encouraging. Because 'cause you're right, I mean, even in the adult stroke world, it's a small world, um, and so there's a lot of overlap there, so all right.
Yeah.
Well, I think you can do it for real. And so I think we can join forces and raise awareness and get everybody connected to their teleneurology care. So,
Yeah, I always tell people, I'm like, just tell 5 friends. Kids have strokes too. It's that simple. That alone can make a difference.
yeah.
We have a team. We have the American Heart Association Heart and Stroke Walk here tomorrow, actually, the Utah
Oh,
one. I don't know if you
tomorrow.
guys do that where you are.
They,
If they have a
well,
stroke walk.
they haven't included Stroke Walk with our Kentucky American Heart Association walk
Oh,
so much. I think they are going to start doing that. But we also have our Kentucky Stroke Association in Louisville where I'm
oh,
at,
okay.
and we do have a walk coming up. I think that's next Saturday that I'll be going to.
Yeah.
So yeah, it's a
Yeah,
great
we
opportunity.
it is, yeah, no, we did our like we formed kind of a pediatric team last year at the Utah one, and invited a couple of patients and families in addition to people from like our stroke team. And I think we
Mm.
ended up being one of the larger groups at the walk. And to me, that was just like such a powerful like
Right.
message because we were just there to say like kids have strokes too, and like the impact that these 3 children who came to the stroke walk had show with like 75 people showing up on their behalf. To me, that just like that's the impact of pediatric stroke, right? Like that stroke
Mhm.
for one child affected all 50 of their closest family and friends
Yeah, it's
that
a whole
showed up.
ripple.
So
Mm-hmm.
yeah, so we're doing the
Yeah.
same thing here tomorrow. We're gonna have a pediatric stroke team at the Heart and Stroke Walk. But I always like to put a plug in for that, just as
For
simple as it is, like kids have strokes too.
It's true, and, now that you mention it, we just had, kind of like a fundraiser banquet for
There he
the
is,
a look at
as
oh, is this your
promised.
doggy? Hi. Oh, do you hear attention happening? You do. You do. What was his name?
This is Humphrey.
Hi, Humphrey. He said hi. I was just gonna say, we did something different for our, like, stroke banquet and
Yeah.
had a stroke survivor and their family come that was represented by, like, all the different sponsors of the event. So, like, all the different rehabs, all the different hospitals from the area sent in, like, a representative stroke survivor to share and, like, they shared a
Hmm.
couple sentences about each one and their inspirational recovery, and so that was really cool because, we
Hmm.
still have the stigma of, a lot of people in the community and even the medical community don't realize that if somebody has a stroke, it's reversible. And then even if it's not reversed by those interventions we talked about, there's still hope with neuroplasticity and
Yeah.
rehabilitation for them to get
Yeah.
so much back. And
Yeah.
so that was powerful. So I wonder if we could bring in some pediatric examples. I saw when I was getting ready for this episode earlier, there was a video of a 17-year-old in Utah. She was a dancer and she had had a
Mm-hmm.
stroke. I don't know if that was one of the patients or not, but having that visibility of, a young person
Hmm.
really does make a difference for them to see and see that their lives are restored and that there's hope
Yeah.
for them. I'm all about it.
Yeah.
That's
No,
awesome. Well, I'm
totally
really glad I
agree.
got to meet Humphrey. You said he wants
So
class,
is
so
he.
I'll to visit.
Humphrey's the
Okay.
one that needs to get over the Utah lifestyle. His vet this week told him that it's time for boot camp. So
Hmm.
he's
Did
gotta
he have
he's gotta lay off the dirty sodas and cookies and start walking more than 3 houses a day. So wish
that's
us
how
luck
the
with that
cookies
endeavor.
crumble. Yep. Next one. All right. Well, if is there anything else that you would want to leave our listeners with, as far as is there anything else you want them to know about pediatric
I
stroke
can't
or
think of anything. No, I appreciate the invitation to be here. This was really very cool, and I loved any opportunity to talk about kids have strokes too. I think
Mhm.
it's really I really appreciate your time and the invitation to be
Yeah.
here today.
So if someone is listening to this and they want to partner with you or learn from you, what is the best way for them to get in touch with you?
Shoot me an email.
Okay. It will be
Yeah,
in the show notes below. And then also, if you have enjoyed this episode of the Nurse Rosa's Insights podcast and you're listening, please like and follow wherever you're listening or if you're watching on YouTube. And you can find me on social media on all the different platforms at Nurse Rosa Speaks or at nurserosaspeaks.com. And I would love to hear from you and know what you want to hear more about or your feedback on what you learned and maybe what you're going to take action about. I would love for some billionaire's ex wife to say, hey, let's throw $1 billion at that idea. That sounded like it might work. So we can dream, right? So,
yeah. My email's available for that too.
yes, exactly. Girl, hey, yes, you're going to be on my short list. How about that? But that's what I'm assembling here on this podcast is a list of options of great things to invest in because these are from people who are on the front lines who see what is missing and what needs to be plugged in for things to work better. And so that's what this whole show is about. So like and subscribe, and I will see you in the next episode.